We know that bladder cancer at the moment in the United States and worldwide, there's no screening program. We have a screening program for breast cancer, for cervical cancer, for prostate cancer. Do you think that's one of the problems, that bladder cancer does not have a national screening program for patients that are at risk?
Yes, I think that's a huge problem. But I think it's also that they haven't really developed anything that you could just say, well, if you test the urine, then, and not all patients have visible hematuria. They might have microscopic hematuria that shows up in cytology, and then they're, given all the normal course of events of the path of least resistance, I suppose, because that diagnosis often involves the cystoscopy, which is a pretty invasive procedure. Mm-hmm. And so I think that really making people aware, because we don't have a test, that when you have the signs or symptoms, it's certainly, if you start to have these things, and particularly if you have any of the risk factors, that might be the equation that says maybe you should have this checked.
And then we often see the converse is true, that patients, many thousands of patients every year, are referred to their doctor with blood that's been detected in the urine on a dipstick, an annual physical, a microscopic detection of blood that the patient's never seen. And even patients with blood in the urine that they've seen with the naked eye, it doesn't always mean that just because you have blood in the urine, bladder cancer is not necessarily the only diagnosis.
Exactly, but until you go to an expert, when you don't know, you should always go to the pro, somebody that knows what's happening with the urinary system. And I think a lot of patients, if it's intermittent hematuria, just when they think, wow, I still have this blood in my urine, maybe I should make an appointment. It goes away, they think, wow, I dodged a bullet. I don't have to call because they're embarrassed. And perhaps maybe a partner sees the blood in their urine in the bathroom or something, and just bringing that to their awareness to say, you should get that checked. Nobody should have blood in their urine. It's not normal.
Now, before we bring Jean and Elizabeth back into the discussion, you obviously have a lot of information available that's guided by the right people to get the right information out there that's evidence-based and accurate. You must see a lot of websites and false information out there. I mean, what are some of the biggest misconceptions about bladder cancer, do you think, that patients have?
I think there are quite a few. First of all, most people don't realize you can get cancer in your bladder. I hear that time and time again when I speak to patients, like, I had no idea you could get cancer in your bladder until I got that diagnosis. And then they come to find out that, well, grandma had bladder cancer. Now, whether it's genetic or not, or the fact that they live in the same environment and grow up in the same culture of foods that they might eat or environmental exposures that they might have, that's not been proven. But the idea is nobody talked about it, mostly because it has to do with the urinary tract and voiding.
Right.
And so that's part of the stigma that's associated with having the disease. Mm-hmm. People don't share that information.
And this is a disease that affects men and women, and we know that it's more common, like many cancers, as patients get older, but it's not a disease confined just to patients in their later years, is it? We do see exceptions to the rule with even patients as young as 30s or 40s with bladder cancer. Do you think, Elizabeth, that we're seeing more bladder cancer now than we were 30, 40 years ago, or are we just better at diagnosing and detecting the disease?
So we're not necessarily better at diagnosing or detecting the disease. I think getting the awareness out there is going to be the key. But as Stephanie said, we don't have a test. We don't have a screening test for it. I think we are actually starting to see a little bit of a downtick in the incidence of bladder cancer, and I'm hopeful that that comes from people are smoking less, and there's just less exposure.
We're seeing quite a lot of people, younger people, still smoking. Older patients seem to be slightly better at heeding the warning, but younger patients who think that they're invincible, oh, this is never going to happen to me, and this is 20, 30 years down the line, there's a huge lack of awareness about the smoking as a risk factor.
I don't think it's awareness anymore. I don't think we can say that people aren't aware however young they are. I mean, cigarette packs in other countries will have graphic photographs of bad things that can happen to you if you smoke. I think it's addictive and it's being marketed, and until that stops, which is slowly happening, we're going to still see smoking. But I think we are seeing less of it in younger generations, and hopefully that will mean we have less bladder cancer to diagnose and treat.
And you mentioned earlier about the role of scientists and researchers. How does that play into connecting with what's going on at the patient level, patients who are having treatment? You mentioned that you've got a lot of scientists and pathologists involved. Are they dealing with research protocols?
They are, and I think that's a really significant thing for patients to understand. We know that a lot of patients could be eligible for a clinical trial, but only about 3% in the cancer space actually participate in clinical trials. And so we know that there's no new treatments. There's nothing for us to get excited about if patients don't volunteer to be part of a clinical trial. And trying to debunk the myths is a really important piece, because people are remembering what they learned in high school about the experimental, somebody's going to get the placebo. They don't understand that with a cancer clinical trial, they're going to get standard of care or perhaps the new treatment. And in many cases, the trials are not randomized so that people know that if they're going to be on the trial, they're getting the new treatment option. And trying to educate patients to get over that fear. And then we're a national organization. Certainly people that are in close proximity to places like Fox Chase have these experts that are doing these trials. But what about people in rural communities or who are seeing their community physicians who don't necessarily bring up the topic of clinical trials? It's important to encourage people to at least ask about it, because they might be getting better care, better monitoring with a clinical trial, and an option for something that's going to offer them some significant benefit. And we try to encourage patients to at least ask those questions and consider being part of a clinical trial. It's not just giving
there's a huge spectrum, isn't there? Some patients are very willing to travel hundreds, possibly thousands of miles to meet with the right expert, and yet other patients really are not prepared to step outside of their local community hospital, even if they're not necessarily getting the best care. How do we balance the best care for patients without travelling hundreds of miles? Do you think that most patients with bladder cancer are within an appropriate geographical area to get expert treatment? Is that realistic?
Well, I think there are pockets where they don't have a center of excellence, where they don't have people that are really focused on this. But I see more and more of the practices becoming engaged in clinical trials and working perhaps with an academic institution that's going to be primarily running a trial, to be able to implement a trial and work with those doctors and be able to communicate, as Dr. Plimack said, that being able to have that open line of communication for someone who's on a trial with their doctor and their community is really important to the success of the trial and keeping that patient enrolled in the trial.